nursing student, well, master's nursing student from Lamar University. And today I'm going to do this lecture about the cardiovascular medications. And I know that you all are going to have a test coming up about this, so I'll print y'all some handouts.
Thank you.
Okay, listen to me, so here's the PowerPoint. Okay, so first I'm gonna go over the objectives with you all. So for this lecture, you will be able, well, by the end of the lecture, you will be able to discuss the regulations of blood pressure. Discuss the regulations of blood pressure in relation to heart failure. So you'll kind of understand, how to regulate blood pressure and medications that's given for high blood pressure. Also discuss the classification of cardiac medications and identify the actions, use, side effects, and other implications for a cardiac medication, and compare and contrast stable and unstable angina. And also you will be able to identify signs of a myocardial infarction. So first we'll just discuss the main diseases in the cardiovascular system. As you all know, of course, you got high blood pressure. You have congestive heart failure. This missing the ear. I guess the picture's kind of cut it off. Also, coronary artery disease, myocardial infarction, and cardiac arrhythmias. So let's talk about the regulation of blood pressure. So what is blood pressure? Anybody know?
Cardiac output and peripheral traffic.
Yeah. So it's the cardiac output times the peripheral vascular resistance. So basically the main thing is you can see here, increase in the output and an increase in the peripheral vascular resistance causes an increase in the blood pressure. So anything that increases either one of these, of course it will increase the blood pressure. So what are complications of high blood pressure? What can we have if you have high blood pressure prolonged? What can that cause? Yeah. You have a heart attack, you can have a stroke, you can go into renal failure, peripheral vascular disease. One thing that I know, like with my patients, even like with family members, they have high blood pressure, but a lot of them, they don't take their medicine because they don't have time or they don't feel like it. So one of the main things I asked him, like, I had a family member yesterday who said that she had high blood pressure, but she don't want to take her medications because she didn't have time to go get it. So I said, oh, so you want to have a stroke? And she was like, a stroke? A lot of people don't know the causes of not taking, what will happen if you don't take your medication with prolonged high blood pressure. So remember that it can cause you to have a stroke, it can cause you to have a heart attack, and it can mess up your kidneys. A lot of our patients that's on dialysis, they're on dialysis because they didn't take their blood pressure medication. Blood pressure's been up for so long, it blew out their kidneys, so now they have to be on dialysis for their life because they didn't do what they need to, taking a high blood pressure medication. And patients have different reasons for not wanting to, but at the end of the day, it's very important to take, try to encourage the patients to make sure you take your blood pressure medication. So let's talk about the inotropic and dronotropic effects of different, medications. So this is important. For inotropic, it affects the strength of the heart. So you have like positive and negative for each one. So for inotropic, a positive effect, it will increase the strength of the heart muscle contraction, and a negative effect, it will decrease the strength of the heart muscle contraction. And then for chronotropic, that affects the heart rate. So just kind of have that relation in your brain, like chronotropic heart rate. So positively, it will increase the heart rate, and a negative chronotropic will decrease the heart rate. And then the last one, it affects the conductivity of the impulses, and this is the electrical component. So positively, it will increase the conduction of the impulse, and negative will decrease the conduction of the impulse. So that's one, y'all might want to put a star by there because that's important to kind of have a understanding of, because with different medications, you want to know the chronotropic and inotropic effect of it, and that will kind of let you know what it's used for. But we'll get into that. So let's talk about preload and afterload. So preload is the amount of stretch of the ventricles. It determined by the volume entering the ventricles. So anything such as hemorrhage, diuretics, vasodilators, that can all decrease the amount of blood entering the heart, which will in turn decrease the preload. So anything that increases the blood volume, such as fluid volume excess, IV fluids, or volume expanders, will increase the preload. Okay, now got that? So for afterload, the pressure against which the ventricles have to contract. So anything that raises the blood pressure will increase the afterload. Anything that decreases the blood pressure will decrease the afterload. And anything that increases the afterload will increase the workload of the heart. So preload.
Y'all need any type of, for the slow down or any type of explanation further, or dig deeper, stop us and let us know.
Yeah. And I'm gonna kind of explain. So for preload, it equals the left ventricular end diastolic pressure. Little, I think it should be on your slide. And it's the amount of pressure that in the left ventricle immediately prior to the contraction. So right before the contraction is the preload. And then the afterload, that's equal to the SVR, the systemic vascular resistance, and that is the resistance caused by the amount of vasoconstriction in the systemic arteries. So the higher the SVR, which is the afterload, the more work the heart has to pump. The more work the heart has to do to pump the blood through the body. Okay. So first, let's talk about heart failure medications. Of course, you have your ACE inhibitors, and one thing I learned, like, if you can see, like in April, kind of April, kind of put those together, and you see the prill at the end. Most ACE inhibitors, they end with the prill, like captopril, nalopril. Most of them, they have the prill at the end. So even when you get out of nursing school later on in life, you kind of like, okay, captopril, ACE inhibitor. And a lot of times it's used for heart failure, and I'll go over in detail to what each classification of drugs is used for. Also, you have your beta blockers here, and they end in the LOLs. So you got your carvedilol, metoprolol, atenolol. All of these are beta blockers. And you just look at the ending. And also, you have your calcium channel blockers. And with that, you have your Norvasc and verapamil, the talisman, and the nifedipine. Once again, I'll go into further detail. So, beta blockers. Anybody tell me something about beta blockers, the action of beta blockers?
They block the beta receptor and
What does that mean that you just said?
it's causing them to dilate. It's causing vasodilation.
Okay. Slow. That's right. So it blocks the stimulation of the beta receptors within the vascular smooth muscle, causing vasodilation. So that's correct. And it decreases the heart rate. So the vasodilation, just to go into further details, the vasodilation causes a decrease in the afterload, which in turn causes a decrease in the workload of the heart. Because remember I said, if you have an increase in the afterload, that's an increase in the workload of the heart. So we want to, the beta blockers is blocking it, so you want to decrease the workload on the heart, which in turn decreases the heart rate because the workload is decreased. So with beta blockers, you have a negative inotropic effect, Does anybody remember what the iron trumpet was? Good. And what about the chronotropic? The, yeah, the heart rate. Good. And so, for the dromotropic, we're not gonna go into a lot of detail with that because that's not a major part of y'all's, I guess it's not, y'all don't really need to know that right now. Okay, so it's, beta blockers are used to treat high blood pressure, prevention and management of, myocardial infarction, management of, angina. Carvedilol and metoprolol are the two beta blockers approved to treat heart failure. Although other beta blockers may be used, but the main two are the carvedilol and the metoprolol.
Okay, yeah, just say like that.
Okay, y'all got it? Y'all not confused? You look like you got a question.
No, I'm good.
Okay, so once again, for the beta blockers, you can see some of the stuff is kind of repetition, trying to hint. So, for the, again, your beta blockers, they end in with the LOLs, okay? Got your metoprolol, carvedilol, those are the two main ones you will see. So, once again, the action of the beta blocker is to block beta receptors in the heart, which causes a decrease in the heart rate, which is a negative chronotropic effect. It decreases the force of the contraction, which is a negative inotropic effect, and it decreases the rate of the AV conduction, which is negative as well. So, beta blockers, all negative effects, okay? So, nursing precautions, you want to make sure, you want to, no, let me ask y'all, what are some things you want to do if you're giving a beta blocker?
Blood pressure, heart rate.
Always want to check the blood pressure and the apical pulse prior to administering the medication. Why should we check those?
People fall out of
I was going to ask why. But the main thing is because of that negative chronotropic effect, decreasing the heart rate. So if the heart rate is low and you give the beta blocker, it's going to lower it even more. Side effects is the fatigue, the bradycardia, which is, okay, lethargy, GI disturbance, heart failure, low blood pressure, and depression. The main thing you see is the bradycardia and the decrease of blood pressure. So what are some other things you want to tell a patient after they take a blood pressure, well, after they take a beta blocker?
Don't get orthostatic
There you
hypotension.
go. Don't get up too fast, it's dangerous. Because they'll drop their blood pressure and then it'll make them dizzy and you don't want them to fall. You gotta think safety. So side effects of beta blockers, once again, decrease the heart rate, may have symptoms of heart failure, drowsiness, fatigue, depression, and hypotension. So here's our nursing implications once again. You want to check the apical pulse. If it's below 60, you want to make sure you question it. Call the doctor. Don't be afraid to ask the doctor. Sometimes the doctor may feel like they still want to give it, but you always want to call the doctor and say, hey, the heart rate is 60 and they have beta blocker ordered. You want me to give it or you want me to hold it? Because you got to have order to hold the medication. So the doctor will inform you if they want you to hold it. And majority of the time, they probably will tell you to hold it with the heart rate lower than 60. So, also check the blood glucose if the patient is diabetic, it can also mask signs of hypoglycemia. So, non-selective beta blockers are contraindicated in clients with asthma. And abrupt withdrawal may precipitate life-threatening arrhythmias, high blood pressure, and myocardial ischemia, tapering over 2 weeks. So for education, once again, you want to teach them. Take your blood pressure before, and also your heart rate. Hold the dose and contact the doctor if it's really less than it says less than 50, or if the blood pressure changes significantly. And do not stop suddenly. or skip doses and report signs of heart failure. So then you have your angiotensin converting enzyme, the ACE inhibitors. Y'all remember what the ACE inhibitors mean? What's an example of ACE inhibitors? So the actions of this medication is to inhibit the angiotensin converting enzyme, which is responsible for converting angiotensin 1 to angiotensin 2 and potent vasoconstrictor and stimulator of aldosterone secretion, which thus the afterload is decreased. And this is used to treat high blood pressure and heart failure. So you want to talk about the RAS?
Y'all remember the RAS? Who can tell me about the RAS? What step does this medication work in the RAS system? At the beginning?
Yeah.
No, not the beginning. Kind of where? After what? What's happening? After the blood goes through the what? What organ? Where does the blood pick up angiotensin 1? Where is it converted? In the lungs. So after the lungs, then it converts to angiotensin 2, right? So that conversion from angiotensin 1 to angiotensin 2 is where this drug is, we inhibit that conversion. That's where this drug helps. It blocks that conversion, but the angiotensin 1 is picked up in the lungs after the blood travels to the lungs. Exactly, because you said, somebody said at the beginning, but what happens at the beginning? It's in an inactive form, angiotensinogen, which is made by the what? The liver, and the kidneys make the renin. They come together, but they're in an inactive form until they travel to the lungs.
Because what happens in the lungs, is that why one of the major side effects is the cough?
Exactly, Samantha. Yes, she was getting to that, but now you're thinking like a nurse.
Yep.
Ace cough is what they call it.
Yep. So is it kind of registering a little better? Okay, so for your ACE inhibitors, your pills, it decreases vascular resistance without affecting the cardiac output, without increasing the cardiac output, the cardiac rate, or the cardiac contractility. It decreases aldosterone, which decreases water and sodium restriction. And also ventricular hypertrophy, it prevents ventricular remodeling. So for the precautions, you want to make sure you check your blood pressure, and you check your complete blood count and your potassium levels prior to administering. And also side effects, fatigue, dizziness, hypotension, orthostatic hypotension, which is, when they stand up and the blood pressure drops, mood changes, cough, headache, high potassium, anemia, thrombocytosis, neutropenia, and angioedema. Now, in my personal experience, I have seen patients that's on long-term ACE inhibitors having that dry, hacky cough, and that's one of the, signs of it. The dry, hacky cough is one of the known side effects of it. And also, lately I've been seeing a lot of patients with the angioedema from the ACE inhibitors, and all of the patients that I've seen, I don't know if it has a relation, has been African American patients. Does that have a relation?
Personal experience, angioedema
Yeah.
around my mouth after an ACE inhibitor.
They
Yeah.
have that mouth-
Hypersensitivity. It's not like you're really allergic to it, but you become hypersensitive to it. But then you have to put it down as an allergy because you can have edema in other places too, angioedema in other places.
And then if they have angioedema, what's one of the things you want to worry about? There you go.
What'd she say?
Airway.
Airway. Ask him what's ventricular remodeling. not necessarily necrotic, but what's happening? Remodeling. Mhm. Exactly. So the heart failure is getting worse, heart failure. What we're trying to treat is actually getting worse. Okay?
So side effects of the ACE inhibitors, increased heart rate, orthostatic hypotension, dizziness, and sexual dysfunction. So for nursing implications, you want to make sure you check the blood pressure, and that's for all blood pressure medications. You want to make sure you obtain a blood pressure prior to administration. Captopril should be administered an hour before or 2 hours after meals. It may be crushed, but for easier administration, so it's okay to be crushed. And check the potassium prior to administration, and also the white blood cell count of the central and hemoglobin hematocrit. For patient education, caution clients to avoid salt substitutes for food high in potassium, unless they're taking a potassium wasting diuretic. And they may get like a taste disturbance, and it usually disappears after continued therapy. And I think you want to make sure you just educate them on like the angioedema and the side effects, basically the cough and everything, so that they can be sure to inform their doctor if they have any side effects. So for our angiotensin 2 receptor blockers, which is the ARBs, those normally end in with the sartan. So you got your losartan and your valsartan, cozartan. So for this medication, it is to block the binding of angiotensin 2 to the receptor site. And
So, yeah. What about the RAS system again? Where does this one work? What receptor site does this block? So we have angiotensin 2 already formed, right? So, okay, so that's after the lungs. Now we have angiotensin 2 in an active form. Where does it go next, the blood flow? To the kidney, but where in specific? Adrenal cortex. The adrenal cortex of the kidney. So it binds, the ARBs actually bind that receptor site to keep that conversion from happening. Okay, remember all these steps along the RAS. Okay, so if it doesn't pick up there, then we have another drug that can pick. That's why you see patients with more than one what? Hypertension medication, because we're working on different receptor sites. If it doesn't work on the first one, hopefully we can catch it with the second one. And then now we have to add a what if the second one doesn't work? What are we adding next? What type of medication? What class will you see them on? What other medication do you see? You have to check their blood pressure for, which she's going to get. Huh? A diuretic. Because why? What's the next step? After the adrenal cortex, what do we have next? The kidneys. Now we need some more help from another organ. Absolutely.
So, in this chart, the drug effects of ARBs are primarily seen on vascular smooth muscles and the adrenal gland. So it blocks vasoconstriction and the secretion of aldosterone. Side effects of this is, once again, the orthostatic hypotension. And if y'all paying attention, y'all will kind of see like the same side effects with the blood pressure medications. So upper respiratory infection, headache, renal failure, and hyperkalemia. So precautions you want to be sure of with administration is to obtain your blood pressure prior to administration. Check the potassium levels prior to administration, and monitor renal labs such as the BUN and creatinine. And patient education, you want to caution the client to avoid salt substitutes or foods high in potassium unless taking potassium wasting diuretic. So then with the calcium channel blockers or calcium antagonists, it's a little acronym. Don't go crazy trying to remember it because it's a lot of acronyms out there, but it's all very nice drugs for calcium channel blockers. And you got your yeah, you can say. Yeah. clozapine and the tyrosine. So the action for this is to block the calcium access to the cells, and this causes a decrease in contractility, and that is, well, as y'all can see, it's a negative inotropic, and a decrease in conductivity and a decrease in the heart rate, which all causes a decreased demand for oxygen. So with this medication, you want to check the blood pressure and the apical pulse prior to administering, and check the LFTs, which is the liver function, and the BU and creatinine. Y'all tell me what the BU and creatinine is for? Okay, and then you want to check that prior to administration. So another side effect is that, well, the side effects, it decreases the blood pressure and it causes bradycardia, and it may precipitate an AV block, headache, abdominal discomfort, such as constipation, nausea, peripheral edema, heart failure, palpitations, and rash. So now let's talk about chest pain. Can y'all tell me some causes of chest pain? Okay. What are some things that can cause chest pain? Okay. Okay. Like a rib fracture or muscle strain? Huh? Yeah. Angina, heart attack, well, for the cardiac area, it can be from angina, heart attack, pericarditis, ectopic beats, and aortic dissection. And from the stomach, sometimes you can have acid reflux or gastritis or ulcer. Working on the cardiac floor, so many times we get patients and they come in with chest pain thinking they're having a heart attack, but it may be like acid reflux. Acid reflux. Also, it could be just anxiety or alcohol, depression, hyperventilation. They can also have pleurisy, cancer, pneumothorax, or PE. So you want to always assume the worst until you rule it out. So you can't never, a patient come in with chest pain, you can't just say, oh, it's just anxiety. You know, you want to make sure this rule out. So what are some of the things or some of the tests that we can do to figure out what's going on with the patient?
Ashley?
Oh, they have a troponin test that they do it at the bedside now. It gives you the results in 10 minutes, and it's faster than waiting on the results. They still send it down to the lab, but this way they know what they need to be looking for.
I picked on Ashley because she just witnessed that today.
Okay, so troponin, another kind of test. EKG.
CK level?
Absolutely.
Yeah.
Which CK level?
Something kind of.
Yes.
Yeah.
Very good.
Yeah. So, this just causes the chest pain. So let's just talk about antiplatelet aggregators. You have your aspirin, you got your Plavix, and your Pladol. So the action of like aspirin, it has several actions, but we'll just talk about the antiplatelet effect for now. And it's primarily given to prevent myocardial infarction or stroke or CVA. So you may see a lot of patients, they just may be on the aspirin a day. A lot of times it's a baby aspirin as a prophylactic. You want to prevent a heart attack, you want to prevent a stroke. And it's also given to maintain patency, like if a patient has stents and vessel grafts. So prevent the formation of clots by interfering with the platelet aggregation. So for aspirin, some of the side effects, you have nausea, vomiting, diarrhea, heartburn. You may have a GI bleed, which is a major thing, thrombocytopenia, leukopenia, neutropenia, and hemolytic anemia, bleeding, and anaphylaxis. And with Plavix, you may have abdominal pain, nausea, vomiting, dyspepsia, bleeding, integumentary disorders such as a rash, thrombocytopenic purpura. And for the other one, you'll have headache and dizziness. So if you take an aspirin and Plavix, you are at risk for GI bleeding and other bleeding increases when both are given together. So what are some precautions we may want to take when giving some aspirin and Plavix?
Check their platelet levels.
Okay.
Give them some probiotics.
That's good. And a lot of times you see the patients on protonics for prophylactic as well. So you want to check the platelet count. That's a good point. Monitor closely for bleeding from any orifice and excessive bruising. So you want to also check the hemoglobin and hematocrit prior to giving, because it'll kind of give you a baseline of the levels. And for the patient education, you want to report any abnormal bleeding or bleeding that continues after 10 minutes of pressure. And you should inform the dentist and other physicians what meds they're taking. And you want to make sure to avoid activities in which there is an increased risk of injury and advise the client to avoid grapefruit juice.
I just kind of want to back up on, we're talking about antiplatelets, and I believe it was Dewan that said protonics. Okay, I kind of see where you're going with it, but let's just not confuse it as a drug that helps with GI bleeding. Okay, we don't want to think that it's for that indication. Protonics does, what is protonics? Right, it reduces the gastric secretions by reducing proton pump, the proton pump, so it inhibits that environment. So what we're trying to do with the proton pump is reduce the acidity of the environment. It's not going to do anything to the platelets themselves, okay? So let's just understand that part.
So now we will discuss angina. We have stable and unstable angina. Can anybody tell me about stable angina? Okay.
To an activity.
Yes. So most of what's stable, it occurs with exertion. It may be like a routine type thing, play sports or something, and you may have a little chest pain. But one of the main things it is relieved by nitro or with rest. Kind of sit down and it may go away. Okay. So for unstable angina, it occurs even at rest, just unstable, like the name says. And it is not relieved by nitroglycerin, and it lasts longer than 15 minutes. So, which one do y'all think is worse?
Unstable.
Why?
Can't predict them.
There you go. What's it?
Like what?
You can't predict. Why are you whispering? That was right. So that's why you want to be careful, because you can't predict it. So that's very important. And then, so I did mention that the nitroglycerin usually relieves stable angina. So we'll talk about the nitrates. And you got your nitroglycerin, the nitrolid, nitrostat, nitrodisc, and a nitrodor, mainly called nitroglycerin. And so the action of this is a potent coronary vasodilator. And it's used to treat and prevent angina. And it also alleviates coronary artery spasm, and it dilates all blood vessels. Venodilation results in decreased venous return of the blood to the heart, which is a preload. So for the IV, it's used to reduce blood pressure during a hypertensive crisis, and also to treat ischemic pain associated with a heart attack, and to treat heart failure and pulmonary edema associated with heart attack. So for nitrates, this one probably is a little weird on y'all, so it's like a word. For the nitrates, some of the side effects is headache, which is one of the main things you may hear patients patient complains of is a headache from their nitroglycerin. Sometimes, most of the time, it comes like in a patch or like a cream you apply to kind of like a little piece of paper with a measure, like a ruler on it. Sometimes it'll be divided. It'll go to an inch, and the doctor's orders will tell you if they want to put an inch or a half an inch. And I notice a lot of you, the higher up you put it, the more the patient complains of chest pain. So sometimes the nurse will put the patient like on the thigh or something like that to kind of prevent that head. I mean, not the higher up you put it, the more they complain of a headache. Not chest pain. So sometimes they'll put it lower to kind of help with the headache, but it does cause the headache because of the sudden vasodilation. So tachycardia, postural hypotension, and dizziness. So make sure for this medication, watch these precautions. The patch should be warm for 16 hours and removed 8 hours. A lot of times the doctors may write an order. It's kind of a standing order for to remove the patch at bedtime.
Hi, Dr. Curl. This is a part of my lecture where we did have some technical difficulties. All of a sudden, my preceptor told me that the video was no longer recording and we missed about 30 minutes of my lecture. It's very unfortunate, but I had to continue on to teach the students because we couldn't hold them longer than the class allowed. So we tried to fix it as much as we can, and once we finally started back recording, the video was kind of turned to the side and misconstrued. So I do apologize for this unfortunate event, and so we'll continue on from here.
Okay.
Okay, so for a diagnosis of a heart attack, patient comes in with chest pain. First thing they're going to do is do an EKG on the patient and also check the cardiac enzymes, which is the troponin, the CKMB. So the acronym for patient having a heart attack is MONA. Most people all know MONA. The morphine, oxygen, nitroglycerin, and aspirin. So the first thing you want to think is the airway. So you want to do your oxygen first. Put your oxygen on them. Then you give them an aspirin. Aspirin not doing anything you want to, well, you just automatically give them aspirin. Then you give them the nitroglycerin. After the nitroglycerin, then you do your morphine. So for your alpha-1 adrenergic blockers, which is like your mini press, this stimulates the alpha-1 adrenergic receptor with norepinephrine, causing vasoconstriction. And the blocking that stimulates prevents vasoconstriction and allows vasodilation and a lower blood pressure. So mainly this is used to treat hypertension and also BPH, but that's totally different lecture. So side effects of this is the orthostatic hypotension and the post-exercise hypotension. Also tachycardia, dry mouth, drowsiness, sedation, constipation, fatigue, headache, sleep disturbance, nausea, rash, and cardiac disturbance. So for the nurse, with this medication, you want to be alert for complaint of a dry cough, dizziness, constipation, or sedation. Monitor the heart rate and the cardiac rhythm for these arrhythmias. Check the blood pressure prior to administration. And for the patient education, you want to advise the patient to exercise, the exercise that can cause a drop in the blood pressure. And avoid the alcohol. So for your alpha-2 adrenergic agonist, you got your clonidine and your albumin. Mostly we see the clonidine in the hospital, and this medication works by stimulating the alpha-2 adrenergic receptor in the brain, which decreases the sympathetic outflow, and the decrease of norepinephrine in turn decreases the blood pressure. So this medication is used for blood pressure, and it's a very strong medication. The side effects of this medication is postural and post-exercise hypotension. Once again, the dry mouth, dizziness, constipation, and sedation. So with this, you want to, oh yeah, it's the same as the other one. Be alert for the dry mouth and dizziness, constipation. Also, you want to A thing with this medication, it can cause a rebound hypertension. So you want to advise the patient not to stop the medication abruptly. That's important with Clonidine. You don't stop it abruptly because it'll cause that rebound hypertension. So for the cardiac glycoside, you have your digoxin, which is a very important medication, and it inhibits the sodium pump, which increases the contractility of the heart, and that is a positive inotropic effect, and in turn increases the stroke volume and thus the cardiac output. So augments vagal tones, causes an increase in diastolic filling. So your decreased heart rate, which is the negative chronotropic effect, decreases the velocity of the electronical conduction and prolonged refractory period. So this medication is primarily used for heart failure and SV dysphagia. So side effects of this medication is confusion, convulsion, color vision. They may see yellow, green, or even purple vision. Important thing is the halos in the vision are flickering lights. Any dysrhythmia includes bradycardia and tachycardia. Toxicity can be life-threatening if unchecked. So I don't know if y'all ever heard of dish toxicity. It's basically too much digoxin. So with digoxin, it's very important that they check the digoxin level because the dish toxicity can kill a patient. So if you have a patient on there, one thing you want to make sure is that you know what the levels are for digoxin. So for the nursing implications, it has very narrow therapeutic windows, so you want to check the serum pH level and watch for anorexia, nausea, vomiting, diarrhea.
Next slide.
Upset stomach or nausea and vomiting is very important.
Next slide.
And arrhythmias. Also check the BUN and creatinine prior to administering, since it is cleared through the kidneys. Renal insufficiency can cause an elevated digoxin level and digoxin toxicity. So before you get this medication, you want to make sure you check the apical pulse for 1 full minute and hold the dose and notify the doctor if the heart rate is less than 60 in an adult, 70 in a child, and 90 in an infant. So that's another, like I said, cardiac medication. You check your blood pressure, you check the heart rate. You want to listen to that heart rate for a full minute with the digoxin.
Why do you think you want to check the apical pulse with this medicine? It's accurate, yeah, but why? What's the reasoning behind it? I mean, you know why. I mean, the hows and stuff, but what's the reasoning?
Because that's the point of maximum control. It's working directly on the heart, so wouldn't you want to check it right where it's working?
But why?
So do you check the heart rate?
Because they're AFib and you try to check it.
Not AFib.
So what if you, like, if you listen to it, you're listening and you don't hear the S1 and S2, are you listening to make sure that you're hearing?
I'm trying to get y'all to think of the concept that I'm looking for. Okay, you check the apical pulse, okay, point of maximal impulse, right? Okay, she said that it's cleared through the kidneys. Okay, so we clear this medication, we have to have good working kidneys. Okay, the apical pulse less than or above 60 means that we have what going on? What's going on with our body? Who said it? Perfusion. If your pulse is less than 60, then you don't have adequate perfusion to the rest of your organs. So if the drug is cleared through the kidneys and the BUN and creatinine is too low, we don't have adequate perfusion. So we need to hold this toxic drug. Does that make sense? Y'all kind of putting it together, putting the little pieces, the little puzzle pieces together as they go. Adequate perfusion needs to be happening.
The drug book also says that some digoxin is metabolized by your gut bacteria, so that certain antibiotics actually kill your gut bacteria, and it can lead to toxicity also.
That's why you have the what symptom? What symptoms up there? Nausea, vomiting, diarrhea. There's your gut right there, right? Okay, go ahead. Sorry.
No, you good. So for patient education, you want to make sure you're telling patient it's important to do not skip a dose, and make sure they, teach the patient how to check their own pulse before taking it, because even with them, they need to understand if the heart rate is less than 60, to be aware. Also, teach them the signs and symptoms to watch for and the signs of dish toxicity, and to follow with the doctor regularly, and caution with over-the-counter meds because there may be some interactions, and take potassium as prescribed. So for antidysrhythmics, you have your amiodarone. It can be given either IV or by mouth, and it's used to control dysrhythmia by inhibiting repolarization and prolong refractoriness and the action potential duration, both the alpha and the beta blocker effects. Okay, so it's used to treat all types of ventricular dysrhythmias, and it may also be used to treat atrial dysrhythmias as well. So it's the drug of choice.
Yeah, that's what they were pushing for that code today. That
Amiodarone.
That's what they were giving during the code.
Mhm.
Yeah.
So remember that, dysrhythmias, amiodarone.
And it's the drug of choice to treat a ventricular dysrhythmia, like she said, during the cold, they're giving it, and sometimes it's given by mouth. So some of the side effects of this medication is hyper or hypothyroidism. So most common side effect is corneal micro deposits, causing visual halos, photophobia, and dry eyes. And one of the most serious side effects is pulmonary toxicity, which can be fatal and leads to pulmonary fibrosis. So you want to watch for these side effects. And also for this med, you want to assess the apical pulse prior to each oral dose, and hold if the patient has a second or third degree AV block. Unless it's, you speak with the doctor about it. Continuous cardiac monitoring if the dosage is being delivered IV. And the clients also taking digoxin or warfarin must be monitored closely, because of the effect of both meds. And with the patient's education, if side effects are coming, and the patient should be warned to notify the doctor immediately for visual changes, dyspnea, and coughing.
Can we back up for a minute? I'm gonna really make y'all think. I bet y'all say, oh, Ms. Craig. Okay, why do you think first and second degree AV block, second or third degree AV block? What's happening in those blocks? Y'all forgot. Too many what? Too many what rhythms? Too many atrial rhythms. Thank you. Too many atrial rhythms, too many P waves, right? Not enough ventricular stuff going on. So if this treats ventricular rhythms, we don't have enough of them. We have too many atrials. Okay? So you need to hold this medication because it treats more ventricular rhythms. Oh, now you're really thinking. Good job.
So now, this medication, you want me to skip this one?
Yeah. Y'all didn't get this one, did you? No. Okay.
Yeah, this.
Yeah, that's really crash cart.
Yeah, this is. So now we'll talk about the diuretics we discussed earlier. We have the loop diuretics, which is your Lasix, your Bumex, and those are all potassium wasting diuretics. So what does that mean, potassium wasting? Exactly. So that is one of the electrolytes you want to make sure you monitor with things like Lasix and Bumex. So the action is to produce potent diuresis, and the resultant decreases fluid volume, which leads to a decreased return of blood, which is basically a decrease in the preload. So this has the following effects. It reduces the blood pressure. It reduces pulmonary vascular resistance. It reduces the afterload. It reduces the preload. It reduces the left ventricular end-systolic pressure, and it's used to treat fluid retention and edema and in CHF, stage 1 high blood pressure, and hypercalcemia. So So for the side effects for this medication, that's dizziness, headache, blurred vision, and tinnitus, which is ringing of the ears, nausea, vomiting, diarrhea. So you want to watch for those. Important one is the hypokalemia. Very important. Also thrombocytopenia, hyperuricemia, hyperglycemia, dehydration, and circulatory collapse.
Miss Arielle, stage 1 hypertension, is that primary hypertension, or what does that mean? Okay.
Yeah, primary, not as secondary to something else.
Yeah. So for precautions with this, you want to monitor the blood pressure and the effectiveness, assess the edema and the lung sounds, assess the urinary output, monitor the electrolytes, especially your potassium, your blood sugar, and your uric acid, because you're excreting your potassium. So check the potassium prior to each administration and hold if potassium is low. Run that by the doctor, because a lot of times you may see the patient on the Lasix that may have like potassium supplement as well to go along with that because of the excretion of the potassium. So be alert of the complaints of the tinnitus and high doses, if high doses are given. And it can be given PO or IV. Yeah, I never seen IV. So your PO or IV. And so you want to push it slow, of course. Medications if you're giving it through the IV. Assess the fluid volume, the vital signs, signs of dehydration. So if a patient is on Lasix, what would you expect to see an increase in? So patient education, you want to make sure they take it early in the day and teach them to take the blood pressure, maintain a log, encourage foods rich in vitamin K, and teach them the signs and symptoms of hypokalemia.
Not vitamin K, potassium.
Potassium. Sorry. Encourage foods rich in potassium and teach signs and symptoms of hypokalemia, and continue to take the meds even if they're not feeling well. And make sure they know not to skip the potassium pill when taking Lasix. And were you gonna say something? Okay. Okay. So with the Lasix, I think y'all most of y'all have given Lasix, right? Mm-hmm. So for the thiazide diuretic, these are also potassium wasting diuretic, and it's like the diuretic, and it works on the distal convoluted tubules to increase the loss of water, and it causes direct relaxation of the arterioles, reducing peripheral vascular resistance, which is the afterload. And this is also used in high blood pressure, anemia with heart failure, hepatic cirrhosis, and corticosteroids and estrogen therapy. So some of the side effects is the dizziness, headache, blurred vision, decreased libido, and impotence, anorexia, nausea, vomiting, diarrhea, pancreatitis, cholecystitis, and blood dysgraphia, photosensitivity, and hypokalemia. Y'all see all of this stuff that it causes. And some of the precautions that we want to take as nurses, you want to check the blood pressure and the potassium prior to administering, because it is potassium wasting. Assess the fluid volume and the lung sounds, monitor the electrolytes, and be alert, complain of dizziness, headache, blurred vision, paresthesia, decreased libido, which is all of the side effects. For your education, encourage them to take it early in the day and teach them to check the blood pressure and maintain a log. It's kind of the same precautions and education as the Lasix. So for your potassium-sparing diuretic, you have your aldosterone, and this competes with aldosterone receptors, preventing the reabsorption of sodium and water, and is used to treat high blood pressure and edema in CHF as well. Here are some of the side effects: the hyperkalemia, dizziness, headache, cramps, nausea, vomiting, diarrhea, urinary frequency, and weakness. So, of course, again, blood pressure medication. Monitor blood pressure and the fluid volume status. Assess the lung sounds and monitor for signs of hyperkalemia. Check the potassium level, especially if they're taking a ACE inhibitor for high blood pressure. For some of the patient education, you want to make sure you trying to get them to take it early in the day, teach them to maintain the log for the blood pressure and signs and symptoms of hyperkalemia, and continue to take them in even if they're not feeling well. And I think that's pretty much it for today, because we are running out of time. So hope they help y'all a little bit on y'all tests.
Yes, it will. It's very organized, the way you laid it out and put all the information there. Thank you.
Yay. Any questions? Okay.